Nursing Care of the Healthy Newborn Part 1. The infant mortality rate is the highest during the first month of life, especially in the first 24 hours. As far as infant morbidity, we look at perinatal mortality. This is fetal and neonatal deaths due to prenatal conditions and delivery circumstances. If these numbers are improved, then the disability rate will be decreased. So let's talk about the newborn directly after delivery. We have 3 transition phases. Phase 1 is birth to 1 hour of age. Phase 2 is 1 to 3 hours of age. And Phase 3 is 2 to 12 hours of age. I know those don't quite match, but that's what they are. We talk about crowning, which is the first view of the fetus. It's where the widest part of the fetal head begins to distend the vulva, and we're actually able to begin to see hair on mother's perineum. After birth, the newborn is usually a pale violet or a blue until they begin breathing on their own, and then they rapidly pink up. Many babies have what's called acrocyanosis, which is a bluing of the hands or feet, a cyanosis, and this can persist for 7 to 10 days. It's not abnormal, but it is something that needs to be noted. Their appearance, they may have a lot of molding, and if you look at the lower picture on the right, you'll see molding there. This is where the bones in the skull kind of reshape themselves to allow the fetus to fit through the birth canal. Those sutures in the skull haven't solidified at this point, so those bones are able to easily shift. The head is going to be much larger in comparison to the rest of the body. The nose is flattened. This allows for easier passage through the birth canal, and it also allows for breathing during breastfeeding. The skin, as you see in the upper picture, may be covered with vernix. This will gradually absorb. The skin may also be blotchy or have a rash. You may see some bruising, and if you look at the picture of the baby in the lower left, you can see that baby's face is bruised. Bruising is usually caused by passage through the birth canal very rapidly. Can also be caused by the use of instruments such as forceps or the vacuum. The baby's face may be puffy. You may see some newborn acne called milia. There can be blood on the skin from the episiotomy, a vaginal tear, or cutting of the umbilical cord. And some babies have what are called stork bites, which are red or purple marks that are found on the forehead, chin, nape of the neck. These will usually fade or disappear with time. As far as hair, some babies have more hair on their head than others, but most babies will have some body hair called lanugo, and this lanugo can really creep down onto the forehead, the upper arms, the back, etc. Most of that will fall out within 1 to 2 weeks. Genitals are frequently swollen, especially closer to term or post-term. Girls can have a creamy white vaginal discharge coming from the vagina. They can also have what's called a pseudo-period with small amounts of vaginal bleeding, and this is because of mother's hormones. The next 2 slides are just slides to help show you the cephalohematoma, which is also the caput it's caput swelling, and it shows you where that swelling is. Nursing care will include cardiopulmonary support and thermoregulatory function. Babies cannot regulate their temperature well on their own. So cardiopulmonary support, we're going to wipe the face, nose, mouth, and or suction to remove mucus and excess amniotic fluid. We'll clamp the cord, we'll stimulate them to cry, and provide oxygen if they are in respiratory distress or they are slow to pink up centrally. We can administer Narcan IM to reverse any narcotic-induced CNS depression also. For thermoregulatory support, we will dry them and then remove those wet linens. Place them on mom's abdomen, cover their back, or we can place them in the radiant warmer. And placing a hat on their head. Again, their head is the largest in comparison to the rest of their body. Part of their body, there's a lot of venous flow there, and they have a tendency to lose heat very quickly through their head. We also can wrap them in warm blankets when they're out of the warmer. The rule of thumb is one more layer to the baby than what mom has. The full assessment can be delayed for maybe an hour to allow for the family to meet their newborn child. The initial assessment will be done for obvious anomalies or injuries, and that's performed immediately after birth. And you can do that very quickly with minimal touching or moving that infant around. The main goal will be to assess and stabilize. As the fetal head emerges, the mouth and nose are going to be suctioned with the bulb syringe, and more aggressive suctioning can be performed if there was a presence of meconium in the amniotic fluid. The head is supported as it delivers. Then after the shoulders deliver, the remainder of the body will slip out quickly. The newborn is frequently placed on mom's abdomen, and it is dried and stimulated. The cord is doubly clamped and cut, often by the significant other. The vital signs will then be obtained every 5 minutes for 15 minutes, every 15 minutes times 3, every 30 minutes times 2, and then every 4 hours. The initial heart rate, we count that for 6 seconds and multiply that by 10. It's often difficult to count a newborn heart rate, so you bob your head or tap your foot in time to the heartbeat. And for some reason, that does make it easier to count the heart rate. You observe for nasal flaring, grunting, retractions, or tachypnea because these all indicate respiratory distress. Fetal heart rates, newborn heart rates are always obtained apically. Respiration should be counted for a full minute. It is no longer recommended to obtain rectal temperatures on newborns because those rectal tissues are so fragile and they're easily torn. We obtain a weight in pounds and ounces and in grams shortly after birth, and then daily at approximately the same time. And we strip the baby down when we get the daily weight. We do the APGAR assessment and scoring, place the ID bands and prints, watch for attachment behaviors, and we're encouraging skin-to-skin contact, and also observe for any bowel and bladder function. Usually bracelets, identification bracelets, will be placed one on the ankle and one on the wrist. This tells you how to use the bulb syringe appropriately. Once the bulb syringe has been used, it should be sterilized by filling it with water and then boiling it for 10 minutes. Now, when we're just removing oral secretions, we don't do this, but if you use it later on to remove nasal secretions, then definitely you need to make sure that you sterilize that syringe ever so often. This is how you obtain the APGAR score. We give 0, 1, or 2 points at 1, 5, and sometimes 10 minutes. Some facilities require 10 minutes, some facilities just 1 and 5 minutes, but at times the APGAR score, if they had a bad 1 and 5 score, then it is recommended to get the 10-minute. But again, other facilities just automatically get it at 10. The APGAR is actually a rapid assessment of the physiologic state of the newborn. It does not predict future neurologic outcomes. The total score, if it equals a 0 to 3, this means that the infant will require resuscitation. If the score is a 4 to 7, then the infant is gently stimulated by rubbing the infant's back or by flipping their feet, excuse me, at the same time that we're administering oxygen. And oxygen can be administered by a mask or it can be administered by blow-by. During this time, if you have the 4 to 7 scores or even the 0 to 3 scores, you need to determine whether the mother received any narcotics or anesthesia that can have depressed the respiratory efforts of the infant, and administer Narcan if available as necessary. If the score is 8 to 10, then there's no need to provide any action other than supporting the infant's spontaneous efforts and continuing to watch them. For infant safety, again, we place the footprints and the identification bands at delivery, and one band will go on the wrist and one band will go on the opposite ankle. Excuse me, the prints will be done and bands placed prior to being separated from the mother. Mom will have a matching ID band, and frequently the father or the significant other will have the second ID band. Most units are closed and locked, and they have cameras and codes, or you have to buzz to be allowed entrance into the unit. You must be alert for any unidentified staff or lingering visitors to help prevent the incidence of infant abduction. We do encourage mothers to room in with their infants, or if they're not in the mother's room, then they should be in the nursery being monitored by the staff. Make sure that everyone who is in contact with the infant observes good hand washing. Infants are administered vitamin K shortly after birth, and this is because a lack of vitamin K at birth puts the infant at risk for bleeding. Tetracycline or erythromycin ointment is mandatory by state law as a precaution against gonorrhea or chlamydia, and this helps prevent those diseases being transferred to the newborn's eyes with delivery. Newborn blindness, the biggest cause is gonorrhea from the mother. It should be administered as soon as possible, but it is okay to wait about an hour to let the mom and the infant establish eye contact. Although, other than just having greasy eyes for a little while, it really doesn't seem to interfere much. Parents must sign an informed consent if they refuse this treatment. The ointment can temporarily blur the infant's vision, but again, it goes away very quickly. And some infants can develop a mild inflammation a few hours after this prophylactic treatment. I've listed the average measurements here of the weight, length, head, and chest. When newborns are left alone and they're not being touched, they usually assume that prenatal position, so they kind of draw back up again. They have flexed extremities that do resist extension, and when you release those extremities after trying to extend them, they do return quickly to the flexed state. Their hands are usually clenched, their movements are usually symmetrical, and they may have some slight tremors when they cry. Their cry should be lusty and strong. Skin color is normally pink, and acrocyanosis may be present, and again, this is normal. Some normal variations would be the vernix in the creases or over the remainder of the body. They may have some cracking or peeling of the skin. Milia is the small, hard, white inclusion cysts that you see across the face. These are not pimples, so don't pop them. And Mongolian spots are bluish black marks, usually above the buttocks, that resemble bruises. And you have some really good pictures of some of these within your book. So when you're doing a more focused assessment on the newborn, these are some of the things that you're looking for. You're palpating the sutures on the head, and there should be a small separation between each one. The hair should be silky and soft, and the ears should be well formed and complete. There should be a startle response to loud noises, and they should be alert to high-pitched voices. The face should be symmetrical in appearance and movement. The parts are proportional and appropriately placed. The eyes should also be symmetrical. They should be clear with scant or absent tears. Both nostrils should be open to airflow. The mouth should be pink in color. The tongue normal size and movement. There should be sucking, rooting, and gag reflexes present. When they eat, there should be a good suck-swallow coordination, and they should retain their feedings. In other words, they shouldn't be spitting up every time they eat. With the neck and clavicles, there should be a short neck, and the head is turned easily from side to side, and the clavicle should be smooth with no bumps or disruption. The chest should be symmetrical, with the xiphoid process sometimes being prominent. The abdomen is rounded, soft. Bowel sounds are present. There should be a 3-cord vessel that should be clamped tightly, and the cord should show evidence of drying. Not right after birth or a few hours after birth, but usually by about 12 hours you'll begin to see some drying of the cord. Genitals. With females, the labia majora usually will cover the clitoris and labia minora. There may be a small amount of white mucous vaginal discharge again and again, vaginal bleeding, which is very normal. With the guys, the testes should be within the scrotal sac, and you need to palpate to make sure that they have descended, and there should be rugae on the scrotum. Upper extremities should be equal bilateral movement with correct formation and number of toes, good muscle tone, and there should be 2 transverse palm creases. Lower extremities should be equal bilateral movement with correct formation and number of toes, along with good muscle tone, and legs should be equal in length. On the back, there should be no openings observed along the spine or any gel in the vertebral column, and the anus should be patent. Again, reminder, there is 1 vein and there are 2 arteries to make up 3 cords in the fetal umbilical cord. This shows you the dysplasia of the hip. Genital age assessment is a tool that will physically measure a newborn's gestational age. It focuses on neuromuscular maturity and physical maturity signs. Each assessment is assigned a numerical score, and the cumulative score will then determine the gestational age. It's frequently done shortly after birth, but recommendations are newborns that are 26 weeks or less should be done within 12 hours following birth. Newborns at least 26 weeks can be performed up to 96 hours following birth, but it is recommended to be done within the first 48 hours of life. Newborns have several reflexes that are present at birth. The Moro reflex is the startle reflex. The palmar grasp reflex is where the finger will wrap around the finger when it's placed in the infant's palm. The plantar grasp reflex is placing a finger underneath the infant's toes and the toes curl around the finger. The Babinski's reflex, when you stroke the sole of the foot, the toes are going to extend and fan out. The rooting reflex, the head will turn toward the cheek that is stroked when the cheek is stroked near the mouth. The sucking reflex, the infant will begin to suck when the mouth or the palate is touched. The tonic neck or fencing reflex is a picture of what you see up here. The infant assumes a fencing type pose where the head is turned and the extremity on that side is extended. The stepping or walking reflex, if you hold an infant up and you lightly touch their feet to the surface of the bed or a table, etc., then they make stepping movements. And circumcision. Excuse me. There has been a lot of controversy about whether to do or not to do circumcisions lately, and this is definitely a parental decision that must be made. Some of the reasons why a circumcision would be done is to decrease the incidence of UTIs, STDs, and cancer. Reasons for rejecting a circumcision can be different cultures or religions or just personal preference. There are two methods of circumcision, and I've shown you both here in this slide. The Gomco, which is on the left, and the Plastibell, which is on the right. The Gomco actually surgically cuts off the foreskin, whereas the Plastibell, a small slit is made in the foreskin and this little plastic ring is placed underneath the foreskin. It's tied off, it cuts off the circulation, and then it will fall off in about 2 weeks. The penile shaft may be numbed with ointment and or a block prior to a circumcision, and we often use a very sugary substance called Sweeties for pain control. This is like a D25, D50 substance, so it's almost straight sugar. And amazingly, it works very well. Providing care for the circumcision, again, we have to obtain informed consent from the parents and make sure that the infant has received their vitamin K. Keep the bulb suction nearby if needed. Excuse me, you can see how this infant in the upper right is restrained, and this is very normal to keep the infant from moving around, and they don't like the restraint. Sometimes I think they don't like the restraint more than they don't like the circumcision itself. We need to keep that circumcision clean and keep Vaseline on the circumcision until it's healed. The newborn is usually going to be fussy about 12 to 24 hours following the circumcision, and then of course we always comfort the newborn. A couple of other things to remember is if you feed the newborn too close to the circumcision, if they cry a lot and they end up spitting up, they're at an increased risk for aspiration. So usually we discourage feeding within 1 to 2 hours of the circumcision. As far as the Vaseline, some nurses will put it directly on the circumcision, and this is what your book recommends. Other nurses will put it on the diaper and then place the diaper up against the circumcision. want you to think about this for a minute. If you put Vaseline directly on the circumcision, then it serves as a barrier for when the newborn urinates, and it helps keep the urine off of that fresh cut. Whereas if you put the Vaseline on the diaper, the urine can still get to the fresh circumcision and it burns. So I'll let you make up your mind as to where you prefer to put it. Most doctors don't care.